Good morning, everybody. Welcome to Grand Rounds. Dr. Slawnych, our presenter, will be acknowledging the ceded lands in part of his presentation. I wanted to introduce Dr. Slawnych, whose title of his talk is Cardiac Palliative Care. I've not met him personally, but it's an interesting bio. He trained as an electrical engineer at the University of Alberta as well as BC and did his postdoctoral work at McGill, a fellowship in Department of Anatomy at UBC. He went on to become a junior faculty member with the Department of Biomedical Engineering at McGill. And then I guess he hadn't educated himself well enough, so decided then to go to medical school at the University of Calgary, where he went on to train in internal medicine, cardiology, and subsequently palliative care. And he's going to present today's Grand Rounds entitled, as you can see, Cardiac Palliative Care. Dr. Slawnych.
Great. Well, thanks, everyone. Good morning, or I guess good afternoon. Thanks for this opportunity to speak with you all. I think it's probably fair to say that many times the paths of cardiology and palliative care usually cross at the most dire of times, namely last few days, perhaps last few weeks of life, when it becomes obvious that someone is dying. I think what my hope is with today's presentation is to kind of give you the perspective that perhaps there's role for more collaboration between these two different disciplines. I like this slide because it nicely kind of summarizes the issue at hand. You know, life's pleasant, death's peaceful. It's a transition that's troublesome. And that's really what we're challenged with. And we see that all the time when we do our weeks of service in the hospital, just the challenges that some of our patients go through. Before I get too far, though, I just want to take a moment to acknowledge with gratitude that we're gathered on the traditional, ancestral, and unceded territory of the Coast Salish people, so the Squamish, Tsleil Waututh, and Musqueam nations. It's always nice to kind of put things into perspective with some case studies, so I thought I'd do that here. So our first case study is a 78-year-old male diagnosed with multivessel coronary artery disease at 68 years of age. He underwent CABG, has a ischemic cardiomyopathy as a result. So his EF is significantly impaired at 20%. He's got a CRT ICD implanted. You can see that on that chest X-ray. You can see it's a pretty big generator. It was one of the initial generations of ICDs that's in there. You can also see there's a couple of ICD leads there. He had a lead that was on recall, so a decision was made to just abandon the old lead, put a new one in. You can also see, if you look carefully, the CRT lead there as well. He's had multiple admissions for heart failure. There were challenges with kind of optimizing medical therapy secondary to hypotension. So he was started on milrinone in hospital IV. So this is almost like dialysis, 3 times a week, 6 hours a session. And he does well for a period of time. And then he has a fall about 4 years later. He comes in, found to have a subdural hematoma. Prognosis at that point was felt to be poor. So palliative care was consulted. There were several new symptoms that were noted that weren't necessarily relieved with the milrinone, including a lot of GI things going on. Some symptom management recommendations were made, including the initiation of morphine for dyspnea, which was declined. And it's not uncommon when we have these conversations about management of dyspnea and promoting an opioid that patients and family members are hesitant. Now, the role of the ICD therapies were also reviewed, and the patient elected to keep all his therapies going on. So he does well for another 2.5 years, although with dose reduction because his pressures now aren't supporting kind of the full dose milrinone. And then finally, the milrinone is discontinued because of progressive weakness and hypotension. So again, at that point, he's reviewed by palliative care. A number of symptom recommendations were made. They were again declined. His ICD therapies were again reviewed, and all therapies were maintained at the strong request of himself and his family members. And then he died at home a few months later, about 10 years after first being hospitalized for heart failure. So I want you to keep that case in mind when we talk about this other case. So an 18-year-old male, kind of the other end of the age spectrum, muscular dystrophy, wheelchair dependent, referred to a pediatric cardiologist at 16 years of age, secondary to very frequent PVCs. I think someone might have their microphone on if they can just turn that off. Thank you. So he had an echo that documented mild LV dysfunction with an EF of about 45%. He had an ICD implanted because of his frequent ectopy at 17 years of age. And then following that, he had multiple hospital presentations for congestive heart failure. Now, he's 18. He comes into the emergency room with dyspnea. Investigations showed some minor abnormalities. He really didn't want to stay in hospital, so he's discharged home. Comes back 3 days later, feeling significantly worse, much more dyspneic, frankly in heart failure. It's hypotensive as well, a number of metabolic abnormalities. So admitted to cardiology service. And day one, he started on inotropes, and echo was carried out. His EFs decreased significantly to 15%. Day two, his condition worsens despite the inotrope support, and he also starts to develop progressive renal dysfunction. So day three is reviewed by the transplant team, unfortunately not a transplant candidate and also not a candidate for mechanical support, i.e. an LVAD. Day four, a decision was made to withdraw aggressive therapy. ICD therapies were discontinued at that time, and palliative care was consulted. And then on day 6, he passed away. So let's just summarize those two cases. So our first case, 78-year-old male, lived for 10 years after getting his ICD, passed away 3 years after his initial palliative care consultation, and he died at home. Our second patient lived for just 1 year after getting his ICD, passed away 2 days after his palliative care consultation, and he died in hospital. So what do these cases illustrate? There's a wide spectrum of heart failure patients with vastly different clinical courses. We all see this again in our dealings, both in our clinics and in the hospital wards. Prognostication is really hard. I don't think anyone would have predicted that that first patient would have done as well as he did for as long as he did. Secondly, things really changed quickly for that second patient. I don't know if I would have necessarily predicted that quick of a time course. Cardiac devices introduce additional challenges, and we'll talk a little bit about that. And then palliative care typically becomes involved in the end of life, the last few days of life. Clearly, that wasn't the case with the first patient, but that was the exception rather than the norm. Now, it's always nice to kind of look at things from a historical perspective. So just to give us that context, let's turn the clock back to 1900. And I'm going to ask some questions here, and maybe I'll get people just to reply in the chat box. What do you think the average age of death was in 1900? What were the top 3 causes of death? How long were you unwell before you died? And where did you die? So I'm just curious if anyone wants to venture some guesses about that. So I've got 42, okay, 40, 45, 40s, yeah, okay. How about top 3 causes? Died at home, yeah. Gil, 38. Why are these people dying? Sepsis, infection, yeah. TB, infection, yeah. How long are people unwell before they die? Days, weeks, less than a month. Yeah, so short period of time. And were people dying, do you think? Yeah. So I think, you're all bang on. So the average age of death is 40. Top 3 causes: infectious disease, accident, childbirth. Disability before death typically was very brief, and people are dying at home. So now let's look at a more contemporary example. So 2010, so the same questions on the table. What do you think the average age of death is? Over 80, 75, 76, 80. Yeah, so people are living longer is what I'm hearing. Okay, what are the top 3 causes of death? Cancer, heart failure, COPD, infection. How long are people unwell before they die? Years, 1 year, 2 years. And were they dying? Yeah. Lots of answers with the hospital here. Let's see how you did. So yeah, average age of death is 80. Top three causes cancer, organ failures that include heart failure, COPD, etc. And then frailty and dementia is in there as well. Disability can be really variable depending on the underlying disease, from short weeks to long years. But most of these people are dying in hospital. And yet when we ask patients, where do you want to die? There's always a small subset that find the hospital reassuring and comforting that you always have the care there. But the majority of patients want to die at home. So let's just turn the tables a little bit and look at kind of prognosis in heart failure. And to do that, again, I'm going to take a little bit of a historical bent and look at the Framingham data. And what it nicely shows is kind of the probability of survival as we march along in years for different decades. And you can see as the decades progress, we're getting a little bit better in terms of survival, but still, about 50% of males are dying at the 5-year mark, and about 40% of females are dying at the 5-year mark. So significant mortality associated with a heart failure diagnosis. I like this paper that was published fairly recently in the British Medical Journal because it kind of picks up where that Framingham data left off. It looks at survival from 2000 to 2017 in a heart failure population, and these patients were identified in family physicians' offices in the UK. And here we've got the 1-year, 5-year, and 10-year survival. And you can see the 5-year survival is about 50%. So it's pretty remarkable that, there's a significant mortality associated with this. And I'm not certain that patients truly understand that. And just to put it into context, what this slide does is it compares kind of 5-year survival rates for heart failure versus various cancers in males and females. And you can see there's several cancers that have a better prognosis than heart failure. But again, I'm not so certain that patients really appreciate that. And there's some examples in the literature of this. I just throw up one here. This is an article looking at patient perception of illness severity and advanced heart failure. So 100 patients with heart failure were interviewed and then followed for 2 years. All of these patients had a predicted survival of less than 2 years, and that prediction was based on what we call the Seattle heart failure model. And I'll be talking a little bit about the accuracy of models in a little bit. So we had 100 patients. Only 16 of these patients perceived heart failure as end of life. 84 did not perceive it that way. Now, just about half of these patients died. So again, our modeling was off. We would have predicted everyone would have been dead in that period of time. But of all those deaths, only 7 were in the subset of patients that thought that heart failure was near the end of life. The majority, those patients weren't at the end of life. So I don't know if those patients really had a good understanding of what heart failure really is. And I put this slide up just out of general interest. Benjamin Oldfield and David S. Jones are physicians in the States, and interestingly, they surveyed the fictional literature to see how much is heart failure mentioned compared to other diseases like cancer and infection. And maybe not surprisingly, they found that heart disease is less represented in the fictional literature. And I wonder if this is one indirect reason why patients perhaps don't really kind of consider heart failure as having kind of the significance that it certainly does to us. Now, to switch gears a little bit, I'm going to ask the question, is there a role for palliative care in cardiology? Clearly, I'm biased with where I'm coming from. But if we look at some basic statistics, heart failure is still the leading cause of hospitalization for people older than 65 years of age. 30-day readmission approaches about a quarter of the patients, so 25%. 6-month readmission clearly is higher. Now, almost 2/3 of heart failure patients readmitted within 30 days are dead within 6 months. And yet only 12% of these patients received palliative care. So why is that? Are these patients not having any symptoms? I don't think that that's the case. Again, when we take a step back and look at the historical literature, I'm always interested by, kind of what we've done in the past. And Hinton was an internist in London, England, and kind of attending to patients on the teaching wards. And what he found is that he was most challenged in dealing with symptoms, not of cancer patients, but of heart failure and renal patients. So I think the recognition is there that these patients have symptom distress. We just have to kind of operationalize, how do we bring in palliative care? So fortunately, we've got our heart failure guidelines that kind of help us. I've listed kind of just a brief summary of the Canadian guidelines, the American guidelines, and the European guidelines, and just kind of generally paraphrasing, the Canadian guidelines say we need to move away from prognostication and provide palliative care based on symptom needs. And I absolutely agree with that. And we'll talk a little bit about prognostication and our challenges with doing that. The American guidelines give a strong class 1 recommendation focusing on symptoms again. The European guidelines kind of emphasize a shared care approach. They acknowledge the value of including palliative care, but kind of shy away from giving a recommendation just because the evidence base isn't truly there. So are cardiac patients getting palliative consultations? So I like this recent paper because it looked at this, and it looked at this from kind of a large American database. So it looked at year of admission and the number of palliative care encounters for heart failure patients. And you can see the numbers are increasing, the trend is upwards, but just look at the y-axis. The numbers are still really, really low. We've gone from under 1% in the early 2000s to around 7% now. I put this slide up just for fun. Basically, what this is a group of researchers in Sweden looked at patients in their last year of life. And they looked at how many medications people were on each month of their last year of life. And not surprisingly, the medications go up. They looked at kind of both an institutionalized cohort, community dwelling cohort, and the overall average. You can see for all of those groups, as patients are getting closer to the last months of life, the number of medications are increasing. I think that probably speaks a little bit to perhaps there's new symptoms and we're trying to address the symptoms, but I think it's more than that. I think we're trying to also kind of quote unquote fix things that are going on. And I would argue that perhaps, it's counterproductive once we have patients on, far more than 10 medications a day. Are we truly taking into account all the negative sequelae with polypharmacy, et cetera? So clearly, there isn't a big interaction between cardiology and palliative care right now. So what I'd like to spend kind of a good part of the rest of my discussion about is some of the barriers for why this is the case. And I think one of the big ones is prognostication challenges. For this, I'd like to go to this paper by Nicholas Christakis and Elizabeth Lamont, published in the British Medical Journal in 2000. Now, Nicholas Christakis is an interesting guy. He's a dual-trained sociologist, physician. Back in the late 1990s, he was asking the question about, how good are docs at prognosticating? He's since moved on and asking kind of real big world questions like how does social media impact healthcare? I wonder if he moved away from prognostication just because he saw some of our challenges with that. Regardless, what this paper did is it asked 343 physicians to provide a survival estimate for almost 500 terminally ill patients at the time of them being referred to hospice. We have to be careful here. This is in the States. Hospice could mean palliative home care. But these were all terminal patients. Life expectancy was thought to be less than 6 months. And importantly, it included both cancer and non-cancer patients. Here's the data. So you've got observed survival on the x-axis, predicted on the y. Only about 20% of the time was the prediction pretty good. Usually we over-predicted things. Interestingly, I'm not presenting the data here, but the researchers also asked the question, if you were more experienced, did you do better? You did a little bit better, not a lot, a little bit, but enough maybe to have us keep going at what we're doing here. I think one of the reasons why prognostication is so fraught with error is because of what this slide is trying to illustrate, especially on the heart failure side of things. Here's a kind of a classic disease course. I'm sure you've all seen these figures before. In cancer, we have kind of a slow general decline followed by a more rapid decline. Heart failure is kind of like a roller coaster ride. You have all these decompensations and you never know when they're going to happen. For some patients, there's a significant period of time between decompensations, for other not so much. And you never know when that decompensation will lead to death. Having said that, that hasn't stopped us from developing tools to try to prognosticate this patient population. And this slide just lists some of them. More than 100 variables have been associated with mortality and hospitalization in heart failure. So you can imagine the challenges in developing kind of a good tool. I put up this slide just to give you a sense of how well some of these tools function. So it's not a huge study, just looked at 138 patients, New York Heart Association class 3 or 4 heart failure. Physicians were asked to prognosticate using one of two, or using two tools. So the qualitative NHS tool, and really what that is the surprise question. Would you be surprised if this patient died, let's say, in the next 3 to 6 months? The other is the Seattle heart failure model, a model that employs kind of clinical demographic data, lab values, device parameters, so a lot of data going into that. So they followed these patients for 12 months and 43 of them died, so about a third. So maybe again, on the chat, you can tell me which of these models do you think did better? I'd be curious to know people's thoughts about that. Anybody want to venture a guess? Yeah. So I think you're struggling a little bit, as I would as well, in terms of, what would give us the best data here. So here's what the researchers found. So with the surprise question, people thought almost everyone was going to die. So 119 deaths out of the 138 patients. So clearly kind of not very helpful. The Seattle heart failure model was at the other end of the spectrum. It predicted only 4 deaths. It got those 4 right, but it missed the other 39. So clearly we're still challenged with this. So what's another barrier? So I think patient misconception, and this comes at a number of different levels. So one of them is about what palliative care is. I think a majority of patients and families have minimal understanding of what the term palliative care really means. A vast majority equate palliative care with hospice. And there's a lot of research looking at this. This is just one example, giving you a Canadian perspective, looking at cancer patients. This is data from one of the big institutions in Toronto. Patients and caregivers were interviewed about kind of what they thought about palliative care. And, patients said their initial perceptions were of death, hopelessness, end-of-life comfort, strong stigma associated with that term. That stigma persisted even after an initial positive experience with palliative care. So clearly, I think we've got a ways to go to kind of educate patients and families about what palliative care is. And that's in the cancer population where palliative care is well rooted. Here's I like this recent paper, kind of gives your perspective, patients for palliative care in the cardiology perspective. I basically have to be on my deathbed. So that was one of the quotes that the researchers got. So, it's not that surprising to me that, patients have that perspective. I think what is a little bit surprising, quite honestly, and disappointing is we also see that on kind of the physician side of things. This paper kind of illustrates that. So it's asking the question, is there a difference if we use the term palliative care versus supportive care in terms of referring patients, again, cancer patients, on for further evaluation? And the oncologist thought the name palliative care kind of was a barrier to referral. It signified decreasing hope and it caused distress in patients and families. And oncologists were more likely to refer patients for primary and advanced cancer treatments to a service named supportive care. Now, this debate has kind of gone on and off in the literature. Currently, it's cooled down a little bit, but there is always a kind of a subset of certainly palliative care providers that wonder if perhaps by changing our name away from palliative care, we'll kind of minimize that stigma, at least a little bit. So what else do patients have misconception about prognosis? If you were just to ask them an open question, do you have a sense of your prognosis? Most will say, yeah, I think so. And then if you ask them to nuance that a little bit more, only about half the time is it in agreement with what the clinicians think the prognosis is. I like this paper because it kind of compares model predicted life expectancy with patient predicted. Again, I've said the models aren't great, but at least it's a starting point. And you can see that patients are all over the place, or at least the models kind of give us a tighter range of life expectancy. Patients also have a misconception about treatment efficacy. And for that, I like to turn to the device literature. This is a paper by Stewart and colleagues published just over 10 years ago, asking patients what their expectations are in terms of a defibrillator. And these are cardiac patients, both with and without an ICD. And they were asked an interesting question. How many lives per 100 would an ICD save over a time span of 5 years? And they asked it in this kind of indirect way because the clinical trials are kind of organized along that line, and we can get a data from that. Thanks, Sandy. I see your answer already. So you can see, the options that patients were given in terms of the responses was less than 5, 10, 25, 40, or greater than equal 50. I wish the researchers would have gone even greater than equal to 80 or 90 or all lives. So patients think that ICDs are really, really effective at kind of saving lives. If you haven't seen Andy's answer yet, what do you guys think the answer is? How many lives is an ICD saving over that 5-year period? No one else wants to venture a guess. That's fine. So it's 7.2, and that's from the Scud-Hef trial. So, but patients don't really have a clue about that. I put this slide up for fun again. It kind of was published in JAMA around 5 or 6 years ago. And it looks at end-of-life care intensity for physicians compared to lawyers and the general population. And what's a little disappointing to me is that there wasn't a huge difference between physicians and lawyers and the general population. You'd think that given that we have context, that perhaps we'd be kind of asking for less aggressive things. Physicians died a little bit less in hospital than lawyers in the general population, but on other indices like surgeries, hospice, ICU admissions, there was no significant difference there. And I found that a little bit surprising, quite honestly. So what's another barrier? There's a perceived unwillingness of cardiology to seek help. I think there's several reasons for this, concerns that advanced heart failure therapies conflict with concepts of palliative care, perceived inability of palliative care to help manage these patients, and the ongoing hope for new therapies. And then there's a perception that palliative care takes away hope. And I like this slide, not the Grim Reaper service. I think basically what this is getting at, again, is needing to educate, quite honestly, not only patients and family members, but also our physician colleagues about kind of what palliative care truly represents. At this point, I'm going to go back and look at the cancer literature a little bit, a paper in the New England Journal of Medicine. I will say that the New England Journal of Medicine has evolved to be a really good repository of palliative themed articles. I don't think this was intentional, but just kind of it's evolved that way. So what this paper is asking is, what are patient expectations about the effects of chemotherapy for advanced cancer? What it's really asking is, what does palliative chemotherapy do? And they looked at two different patient populations, those with lung cancer, those with colorectal. And, not surprisingly, a lot of patients in both these groups thought that it was very likely or somewhat likely that the chemotherapy was curative as opposed to palliative. Again, that doesn't really surprise me. I think what surprises me more is a secondary question they asked. So they asked the participants in this study to rate their physicians as communicators, okay? And, patients who reported higher physician communication scores kind of had more inaccurate expectations. In other words, patients perceive physicians as better communicators when they convey a more optimistic view of chemotherapy. So if that you're that physician having that frank conversation, I don't think this is going to go well, you're actually viewed as a worse communicator, even though you're kind of being completely honest and expressing what that chemotherapy is actually doing. So what's another barrier? End of life conversations. These are hard. I think there's patient-related barriers and physician-related barriers. On the patient side of things, patients don't initiate these often because perhaps they are not even aware they should be in some cases. On the physician side of things, there's perhaps a lack of key moments to start this and several other factors. Here's a slide of a kind of an abstract presented at one of the heart failure meetings in 2015, then subsequently went on to be a publication. And you can see here's some reasons why perhaps physicians don't discuss end-of-life care with heart failure patients. Lack of time. Quite honestly, I would have thought it would have been higher because these conversations do take time. Afraid of destroying the sense of hope, absolutely get that. Uncomfortable bringing that up, for sure, I get that. Perceive that patients aren't ready to talk about it, yeah, for sure, but maybe patients aren't talking about it because they don't know that they have to talk about it. Again, another slide just for fun from the New England Journal of Medicine again. Really what this is kind of getting at is, where do patients and family members get their information from? And it's really TV and I guess now social media. So in 1996, the New England Journal of Medicine published this article, titled "Cardiopulmonary Resuscitation on Television." And they looked at 3 shows: Chicago Hope, ER, and Rescue 911. So these researchers watched all the shows and they looked at kind of survival after CPR. And you can see that for Chicago Hope and ER, the survival is about 2/3. Rescue 911, it's 100%. I get the trainees, certainly on the palliative trainees, to read this article. And one of my take-home points is that if you're an actor, hopefully you've been on Rescue 911 because at least you have the chance of kind of coming back to act on another episode of it, because you will have survived your cardiac arrest every single time. So that's on TV. What about real life? So Adams, this goes back a little bit, 15 years ago, but he went into the emergency departments, into the internal medicine clinics, onto the wards, and asked patients, elderly patients, and the definition of elderly here was 70 years of age or older. He asked them to kind of state what their likely chance of surviving a cardiopulmonary arrest is. And you can see there's the data. So the patients think their survival rates are quite high, significantly higher than what the literature would show. And before I show you kind of some contemporary numbers there, again, taking a giant step back, the Royal Victoria in Montreal was one of the first hospitals to set up a resuscitation team. And in this paper here, they nicely published their kind of 10-year data from right at the beginning, 1960 to 1970. So this is when CPR is really just coming in its infancy. And you can see that the overall survival from hospital was 20%, close to 20%. It's not bad. I will say that they restricted their resuscitation efforts to VT and VF, okay? Here's some more contemporary data. And, if you were to ask just the open-ended question, what is the likelihood of survival? It's a bit of a trick question because it depends. It depends on what the rhythm was. And sorry, I'm trying to keep track of the chat too. And Andy says that St. Paul's Hospital was the first in BC. Nice to know. The overall survival rate as we march along in years is probably about 15 or 20%. If it's VT or VF, it's kind of 40%, some literature says 50%. PEA or an asystole, it's lower, and that drags kind of the overall average down. Okay. So how do we move forward? This is an interesting recent editorial, and it says maybe we have to advocate for moving away from quantity of life to quality of life. It's easy for us to say as a non-patient, clearly from the patient perspective, there's a lot of literature showing that patients still highly value quantity of life as well. I like this article by Jennifer Tamel. It's published in the New England again in 2010, a landmark article. It's actually been cited over 4,000 times. Basically, these researchers asked the question, if we provide quote unquote early palliative care to a patient population with advanced lung cancer, do they feel better? And do they live longer or shorter? I think we can all make that hand-waving argument for why patients might feel better. Palliative care has that time to do that detailed survey and attend to various symptoms that patients are having. But I think what was surprising to a lot of people is that patients live longer too. In the standard care arm, the median survival is 8.9 months. In the early palliative care group, survival was 11.6 months. It was longer. And people have speculated, as to why this is the case. And one of the reasons might be a little bit less chemotherapy by the time you get down to the second, third, fourth lines of chemotherapy, or patients just getting mostly harm and no benefit. It would be interesting to repeat this study with kind of the current era of therapies that are available in oncology now. Here's a little bit more recent data, just showing the benefit of routine symptom monitoring in patients with metastatic cancer. And you can see just by monitoring the symptoms, patients seem to be living a little bit longer. Again, that's a cancer population. Do we have anything on the heart failure side of things? Probably the best trial is something called Palliative, published around 4 or 5 years ago. Not a huge trial, 150 patients, advanced heart failure, randomized to usual care or usual care plus palliative care intervention. In the palliative care arm, these people had better symptom control, but there was no significant change in mortality. I kind of saw this with interest recently, that someone is doing another trial that'll be a bit longer, perhaps more intensive palliative interventions, and perhaps we'll have some more data in terms of kind of the true benefit of palliative care, above and beyond the symptom side of things. So how do we move forward? I think, there's a couple things that we can work towards. So first of all, I think interdisciplinary collaboration, I think, is really important. Instead of this kind of binary all on, all off for standard medical therapy and then palliative care, I think there's an opportunity for kind of both of these to work in concert, with kind of more palliative care and symptom-focused therapies coming into place as heart failure burdens increase. I think palliative care and prognosis should be delinked. I've shown you that we're so bad at prognostication. I don't see us getting better anytime soon. Perhaps, but nothing kind of on the early landscape anyways. I think we have to promote palliative care education for both patients and physicians. And what I mean there is we need to tell people what palliative care truly is. Here, I'm on the left side, I've got what the perception is. You've got this big oval that's curative and life-prolonging therapy, and you've got that little circle off to the side, which is palliative care. So there's no interaction between the two. And then most of that palliative care circle is taken up by hospice care. But this is kind of the model that palliative care likes to promote, kind of an interdisciplinary collaborative model where there's roles for palliative care to work in conjunction with kind of ongoing therapies in the various disease domains. And importantly, hospice care only represents a really small part of palliative care. I think, we have to kind of pick up the torch and start to have these hard conversations about goals of care, end of life care, and resuscitation wishes. This is a paper that I like to give the trainees, published again in the New England Journal of Medicine around 10 years ago, Freedom from the Tyranny of Choice, Teaching the End-of-Life Conversation. Basically, what this paper is saying is we have to move away from presenting kind of our goals of care landscape as a menu that patients choose from. And the problem is that's a menu without context, right? You know, timely referral to palliative care. I just listed a few triggers. You know, perhaps once you've had a few hospitalizations for heart failure, that's the time to really start thinking about the role of palliative care in that patient population. You know, I have a particular interest in kind of devices near the end of life, and I think we can do better. And I think, honestly, the conversations about defibrillators should happen before we even put them in. We should be frank with patients and saying that this makes sense right now, but there might be a time in the future when your clinical condition significantly deteriorates, either because of worsening heart failure or other cardiac disease, or because of a different diagnosis, like a cancer diagnosis. Then at that point, there would be time to kind of revisit what the ICD does. These conversations rarely happen. And then when we come in and start having conversations about turning off the defibrillators, patients and family members are quite distressed about that for several reasons, including kind of a lack of kind of true understanding of the efficacy and the context of these devices. So, you know, that's mostly what I wanted to talk about today. So, you know, again, I'm biased, but I think cardiology and palliative care can be more complementary. We're not there yet. Only 6% of patients with heart failure are referred for palliative care during a hospitalization. I'll just kind of point you in the direction of our Choosing Wisely guidelines. So Choosing Wisely has, you know, a set of cardiology perspectives, and basically, just to really simply paraphrase it, don't test asymptomatic low-risk patients. But look who else has a Choosing Wisely set of recommendations. It's palliative care. And what palliative care, kind of the recommendations that I'm not so certain that we always attend to, is don't delay palliative care for a patient with serious illness just because they're pursuing disease-directed treatments. And don't delay advanced care planning conversations. I'm just going to finish with kind of a small plug. I'm hoping to start up a conservative management cardiology clinic kind of later in the spring, early summer. You can see that I was careful in kind of not choosing the term palliative. Again, I think it has a negative connotation. I've stolen the term conservative management from some of my colleagues in Calgary, in particular one of my nephrology colleagues who started up a conservative management clinic for end-stage renal patients who didn't want to pursue dialysis. So I kind of slimmed my presentation down a little bit just to hopefully, you know, leave some opportunities for questions and discussions. I'd be curious to hear what everybody says. Thanks.
Thank you, Dr. Slawnych. We'll take questions from the chat box and in person, but I have one question, and it's probably been addressed, and you probably addressed it, and I might have missed it. Is that in the patients that are deemed, I guess all therapies that aren't curative are palliative, I suppose. So it's what's in a term. But is there do you think part of the resistance is changing caregivers in the in quotes palliative component of their illness versus continuing the same caregiver who's changing directions?
Yeah, interesting. I think, you know, there's certainly if you've been following the patient for a long period of time, the patient, you know, has a level of confidence with their main physicians. I know I use kind of the palliative care term broadly. I think we're all palliative care physicians. So a lot of what I've talked about doesn't necessarily require specialist palliative care. I think the other thing that I'd like to mention is that sometimes the main player, the main physician for patients is the family doc. And I think in some respects, sometimes the family docs kind of feel left out once patients kind of get connected with heart function clinics and things like that. I'm new to Vancouver, so I don't really know the landscape here, but I know in Calgary, you know, many times, you know, when the family care physicians tried to kind of come in and adjust some medications, they would get their kind of hands, quote unquote, slapped by, you know, the care group saying, how dare you kind of enter into our domain. And then it's like the family care docs or kind of abandon those patients. They're and yet these importance should probably be the most important, some of the most important physicians for these patients.
Great, thank you. There's another question from the chat box. Can you comment on how to best access palliative care for outpatients with non-malignant disease? That's from Dr. Trothill.
Yeah, so that's a work in progress. You know, again, where I came from in Calgary, we're fortunate. We formed kind of a non-malignant palliative care interest group for a couple of reasons. Number one, to advance palliative care in that patient population, but also to importantly, to kind of do some training and teaching with our trainees and some of our colleagues. And we were fortunate in the sense that we had a nephrologist, a cardiologist, and myself, a respirologist. We were kind of close to getting a neurologist as well. So, you know, once you have that critical mass, then I think things start to get going. Again, I'm brand new here. I'm hoping by setting up my palliative clinic sometime in the spring, that'll kind of help to start that getting going. And I suspect that there are like-minded people here as well in other disciplines like nephrology and respirology and neurology.
Dr. Ignashevsky asks, what do you suggest we do at PHC?
Yeah, I think the starting point is this conservative management clinic. You know, there's still lots of questions about the best way to integrate palliative care and cardiology, certainly on the inpatient side of things. There's some kind of a little bit of literature of integrating, you know, palliative care teams with the heart failure teams in the hospital. You know, the data that I've seen so far hasn't been that promising. I don't know if it was just the way that the integration was. It's still a work in progress on the inpatient side of things, but I'm hoping with kind of this conservative clinic that I'm opening up, it'll at least start to open some avenues.
Are there any questions from the discipline of palliative care or any of the other disciplines? Or comments? Well, if not, thank you very much for a very, very, very interesting and thought-provoking lecture. I think we'll all begin to, I know from my colleagues from palliative care before, they've initiated these thoughts, and certainly in our patient care, and it just is further evidence that we need to continue to think about these things. So thank you very much for the presentation. Next week, Dr. Christine Chapman will be talking to us about the advances in the treatment of complex nerve injuries. So thank you again.
Oh, pleasure. And I just want to say that Gail's pointed out that there is an outpatient general palliative care clinic as well at St. Paul. So, you know, an opportunity for kind of some collaboration there and to expand that. So
thank you.
Okay. Bye-bye.